So today we're going to talk about breaking down barriers in health equity. And as we get into this, first of all, I always enjoy learning a little bit about people that are speaking to me when I'm in presentations like this. So just from a who is this person and what does he know standpoint, I thought I would share a brief background. The majority of my career has been spent in the insurance side of the plan space, and then in the plan side of the plan space related to supporting technologies. I've been doing this for nearly 20 years, and the majority of my career outside of that little stint in radio has been in the health insurance or HIT space, health information technologies. So what I bring to today's conversation is years worth of consulting with large employers about their benefits and the insurance, and then helping build an analytics organization that solves problems, identifies gaps, programs wellness for large employers and health plans. And then in the portal space, the engagement space, and here at PDHI, we focus very strategically on the communication tools and the technology that supports the initial member and the ongoing member communication related to health assessment process and supporting process. So today, we're going to spend a little bit of time covering a look into the function and features needed to gather information from your members. We're going to talk about best practices related to outreach. We're going to talk about some success best practices and data mining best practices. I will say I appreciated the comments. Sherry was able to provide us a little view into some of the "I hope I get out of this session" comments that you all put into the registration. And many of those comments were related to data management practices, best practices related to engagements and outreaches. So those are definitely things we will cover today. Hopefully this is a very informative session. I know we have about an hour. Our plan is not to take anywhere near that much time. So we do have time at the end planned for QA, which we will get to. So I'm going to jump right in here. Before I do that, I'm going to make a statement that I'll repeat a number of times through our conversation today. And that is, I believe that the health assessment process, when done correctly, is one of the most important initial member outreach and engagement tools that your plan has, your organization has the ability to connect with members, whether it's a new enrollment, whether it's an AEP period where you're collecting data. Again, I believe this health assessment process helps you combine multiple types of process into one and provide you what we'll refer to as a leading data set, exceptionally valuable. So as we jump into talking about where we're at, and we're talking today about social determinants, SDOH, how they relate to your plan, how you do things with them, I wanted to level set us. And our team had a conversation internally about that term. It might be an old term. So what we're going to talk about today is bringing everybody onto the same page before we get going, because when we say SDOH, right, which has now become a buzzword in many ways, I even have a counterpart who we joke all the time. Well, he's not joking, but the concept of SDOH has trickled its way even into the employer workforce area, right? But many of these things, as you know, are things you've done for a very long time. There's nothing new really around SDOH other than it has boiled up to become this quality measure. It's now a metric from a scoring perspective related to quality. You will understand that well more than I do. And so the concept is social determinants of health. And it is in a sense a buzzword, but there are so many things that can make it confusing. So we're going to define just real quickly here. There are a handful of tools and programs used related to social determinants, and this will tee us up to what we're going to focus on today. So as we begin this discussion of social determinants, and again, you're all vastly more aware, the hands-on day-to-day of what's going on here than I am. But I do know there are many tools related to the outreach of members and surveys of members. There are organizations that exist once you've identified members that might be subject to or identified in a certain category of social determinant. You might engage them to go to a secondary survey. with these members to gather more information about this certain topic or this certain issue. You may engage them to do outreach. You are probably doing outreach to these members already in multiple fashions across multiple areas of your business, your organization. The data with social determinants is used, right? Data is used to stratify members. You have created this robust process by which you consume multiple disparate sources of data. We'll talk about that here just in a minute. And then you identify areas where your plan can intersect and support that member. There are some programs related to the outreach or the connection with resource pools to these members. Maybe they need transportation, maybe they have housing insecurity, they have food insecurity. And so you might, in your area, within your network, have a list of organizations that you connect them with that can help them, that you use as a partner. And obviously you've designed programs with the data, with the information, with the surveys, with the conversations. You've designed programs to help support members in certain areas of social determinants. The whole idea being we're doing all of these things as a plan and as an organization like ours to help our partners, our clients, meet your internal goals, because you inevitably have someone like a CMO saying, we have to solve X. And so you're using all of your talent and your abilities and your resources and your connections and your partners to solve X. You're meeting internal goals and you're focused on improving quality for the members as well as for your plan. So I mentioned data. Disparate data exists. This is nothing new. You have probably a team, if not a building, at least a very large room of people that their goal, their job on a day-to-day basis is to manage this massive amount of data that exists coming into your organization. Everything from prescription, EHR data, radiology, disease state data, outputs from your BI and your analytics platforms, claims data, all of these components, these pieces of data exist, and they're there. And if not done correctly, the outputs, right? The things you're building, the programs you're building, the outreaches you're building could be wasted effort, or they could be minimized effort because the data is either old or incorrect on that member. And so it's important. We will talk in just a second about two types of data. There's lagging and there's leading data. Lagging data being things that's old, leading data being things that helps us understand what's happening right now and into the future. So we know we have all these data sets. Let's talk real briefly about what we're doing with these data sets. Again, nothing new here. You're using the data that you receive to identify risk. You're using it to assign members to case management, care management, disease management, utilization management, et cetera. You're doing all of these things with the data that exists. You're managing incentives potentially, which is used to encourage members from a gaps perspective or a completion of a task perspective, whether that's a challenge or completing a health assessment, for example. You're also using the data for what we're talking about today, identifying issues related to social determinants. And then from that, you're probably building some cohort groups. This is just the tip of the iceberg, right? You know these things. You're doing these things today. I mentioned disparate data. I mentioned lagging and leading data. There's an example here of a client that was using data to identify an issue, right? If they were going to program for wellness, for example, or outreach, they wanted the most relevant outreach to the correct member set, and they were using claims data. And as we know, depending on how you process claims data, at best, claims could be real time, but most of the time they're a matter of days, weeks, months, sometimes even multiple months. If you're taking on a new member, let's look at that for an example standpoint. You bring in a new member to your plan and you don't have any historical data whatsoever. You don't know what they need. You don't get that 12-month dump many times of the data that you can then consume, run through BI, triage them into, stratify them to the programs that they need help with, outreach from. And so you're left in a bit of a void until claims start occurring. And many times those claims could be too late before you begin to gain intelligence on that member. So leading data, that's kind of the lagging perspective, right? The wrong data, it's lagging. Leading data is data that allows us to understand what's happening with that member right now. They're reporting how they feel, how they interact, the things they're looking for, the issues they're having, and it provides an actionable outcome. It provides the ability for an actionable outcome as quick as possible, many times quicker than other data sets. So I have a friend who is a runner, and Stephanie is actually a runner as well. I think she has a goal to run every day. She told me once. I don't know what that looks like. It's not something I can do. I've never gotten into running, but I have a friend who I was talking with, and they're staying with us for a short period of time as they're here in the States. They live overseas. And as soon as he landed in the States, at my front door, there was a box from Amazon, and it had a new pair of shoes. And so I'm like, these are different shoes. I haven't seen these before. Tell me about them. And he started telling me about how important shoes were with running. There's the shoes, there's the socks, there's the attire, right? Depending on the weather, you have to have the right performing gear so that he can endure, because he does lots of marathons and long races and things that just make my mind go tilt, that I just couldn't do. But I know people do these things, right? And so I was asking questions, and I began to understand how important it is for him to have the right shoes, to have the right gear. Specifically, he said there's only a certain number of kilometers that he can put on a pair of shoes before they're no longer efficient. They no longer serve him. So he has to get a new pair of shoes. And I started thinking and relating this to data. And I'm like, that's very similar to what we do here at PDHI. We help our clients use something that they have, right? He's probably got 10 pair of shoes in his closet. We probably have multiple ways and pieces of data that we're consuming every day and using to make decisions. Is it the most effective? Is it the most accurate data? And so I relate the shoes, the technology that he uses to perform at his best, to the proper health assessment done at the time either a member is new to the team, to the plan, or maybe it's the AEP, the annual enrollment period, and you're redoing that look with the member. Just to take another snapshot, every plan is different in how they approach that. And so having the right gear does make the difference. I think it was Einstein who was quoted for saying, I don't know if it's accurate, I've read a lot about him not actually saying this, but it's still attributed to him. If we're going to do the same thing every day and expect a different outcome, it's crazy. It's ludicrous, right? We're not going to achieve it. And so sometimes we have to tweak the process, get better at our process, take on a new data set to make us better, give us more insight with our members. We believe that the health assessment process is a vital leading data set. It is one of the key, I can't say it's the only, there are others, but I believe it is one of the most vital and most important leading data sets as we start talking about what's the data that I can capture on this new member to my plan that will give me the information today, potentially within hours after they've completed it, so that I can put them into the right care programs. I can reach out to them with assistance for food, security, housing, transportation, whatever those primary needs are related to social determinants. We have the ability in the quickest amount of time to grab the data and use the data. They're a vital leading data set. Yes, for social determinants. They help us understand these things. Yes, for the ADLs, right? If you have a duals member or you have a Medicare member, you need, and it could be a series of different types of members, but you need to understand, are they able to do these things? Because if we don't know this until it's too late, there could be a fall, there could be an injury, there could be a claim. And that affects the member's experience with the plan potentially. It affects the claims paid for that member, and then even lifestyle. What are their preferences? Are they a smoker, not a smoker? What are their eating habits? What are their exercise habits? So understanding those behaviors help you identify the needs that the member has so that you can align with some of the great programs that you already have available or that you're currently building to support members with issues like this. We talk about best practices for the initial outreach. So we're getting a little bit into PDHI, and we have a quick summary of us. We've tried to make this very educational, but Sherry did say we could share a little about us. And so we'll do that. We've been doing this for 25 years. We have lots of health plan clients. We have lots and lots and lots of member populations that we've supported from an initial health assessment. Now that health assessment should, right, from a best practices standpoint, there are things you should be doing with your health assessment process. We still find the majority of the clients that are moving to us are managing a bulk of this process internally. They've been doing it internally. They've built the questions, they've built the process, but they're having issues with certain things, either completing the calls or getting the mailers sent at the right time, or getting paper in the hands of those who need a paper form. Maybe it's the initial outreach call, helping them complete those assessments. And so we hear over and over that most plans are doing the things they have to do. There may just be a bandwidth issue, or maybe they've come to a point where they believe they need to be accredited specifically in the area of their assessment, so they can take auto credit next time they file for NCQA. And so these are things that boil up to why clients contact us, why prospects contact us, and we begin a partnership to help them solve these problems. So I'll share a few things related to best practices when you start talking about building the health assessment process internally, or using a partner to manage the health assessment process for you. Number one, it has to be timely. You all know the rules and regulations. You're all operating with the, if it's Medicaid, Medicare, you probably have somewhere between a 90 and 105, 115 days that you have to reach the member a certain number of times. You have to provide them a certain number of different ways of information, et cetera. And what we also find is plans that are saying we're sending the mailer, we just don't have the ability to make the calls, or we're placing the calls, but again, we can't get the mailer in their hands quick enough. So one of the key things, this first button, this first highlight for best practices related to member outreach to the annual enrollment process with the health assessment, is that your members are different by line of business. I know this isn't earth-shattering. I know you know this, and you have discussions every week around, are we doing the right things for this type of population? And so we see a different workflow, and I've got an example of a workflow that we'll pull up and we'll look at. But if you're not building a separate workflow for each of your member population types, you're missing a key opportunity to reach that member where they are and gain the most impact with the member, et cetera. So an example might be in a Medicare population, since it's less expensive to send paper and they might be more prone to complete paper than to go online and complete a process, it is more efficient to have a workflow that that outlines multiple sends of a paper mail reminder to complete, or an actual paper application. Right. So that should be configured by line of business. Many of our clients have multiple lines of business. They're dealing with Marketplace, Medicare, SNP, Medicaid, commercial populations, and each one of these lines of business should have a separate workflow. We hear limitations from some of our clients coming to us with the frustrations of what they're doing. They either don't have the bandwidth to manage multiple workflows to most effectively reach the member, or the vendor they're currently working with can't manage the complexity of workflows that they need to build in order to effectively reach their members. So configuration of a workflow by line of business, this is key. This is vital to the impact you'll have in that market. The second thing is utilizing technology as much as you can. The majority of populations have some access to technology. So the completion of the health assessment process, and then secondary to that is so what we'll call self-management tools. As most populations, most of you on the call today, I think will understand, we refer to them also as action plans. These are tools that the member has access to once they've completed their assessment. The assessment is identifying areas of possible improvement or areas that they might have interest in learning more. So there is a series of modules. We'll look at these real briefly here in just a second, that we make available, that without additional human interaction, the member can complete the assessment. They can receive a report on their results, kind of a red, yellow, green, right? Understanding the impact. And then from there, there are tools that can be lined in to support areas of need with that member. And so that all yields to the meet the member where they are. And this is where we talk a little bit more about a multi-channel approach. Does your approach include a multi-channel way for the member to connect and communicate with you? Are you limited to paper mailers? Are you limited to paper forms? Can they do the assessment online? The majority of Americans today, yes, even your Medicare Advantage populations, can use a survey digitally. And so if we're not providing that option for them, then we're missing the ease of completion and the ease of education, the experience that the member has. So your outreach should support and provide a multi-channel engagement through your member portal, connecting to a platform like the PDHI platform to capture data. But then from there, can you remind them via SMS? Can you send them information via email? Are you sending them mailers? Is there a team placing a call just there to help remind them that this health assessment should be completed within a certain amount of time? If they don't have time to do it via paper or online, you could help them complete it on the phone right now. Are these things being made available to make the process easy for the member to complete so that you get what we've already started talking about, this incredibly rich, incredibly vital leading data set that informs your efforts and makes your efforts more impactful for the member? I talked about the workflow. I'll share just real briefly here what a potential workflow might look like from the time of enrollment to the time of the process. These workflows, as I mentioned, should be designed by line of business. If all you're doing is Medi-Cal, then you might only have one workflow. But the majority of plans have multiple types of outreach, that there are multiple types of populations, multiple lines of business that they're managing. And even within that one line of business, you may have a SNP population. You may have a population that requires some additional assistance or touch points. And so develop a workflow specific to the population type. This will enhance your ability to reach the members. I throw this in here because I mentioned this a couple of slides ago. Members today, how many times when, like, I just went to a doctor visit earlier this week to talk about this new thing they want to do, and how many times are we using this device to research what we're going to do? We use it to buy TVs, right? We use it to look into the stats of the car we're looking to buy. We're doing, as Americans, we're doing research on things before we make these purchases. And the same is true with healthcare. And so if you're not providing these tools to the member, they're going to try and find them elsewhere. So why not provide them? Why not provide them a library of information where they can research conditions or medications? Why not provide them tools to help them on their own improve their health and learn? Maybe they just got a diagnosis of they're pre-diabetic. What does that mean? What should I be doing? Should I change my diet? So having these tools in front of me and available to me are important to help the member. It improves that member experience. It elevates the member experience and the process. I mentioned a little bit about us. We've been managing the health assessment process and the supporting technologies for over 25 years. We have lots of lives on the platform. This is a platform we've built ourselves. We help our plans, our clients, capture data, use valuable data, and then this data is used to stratify into programs, whether we're creating an outbound stratification, or whether the client is doing it. Most of the time, our clients have a really good BI platform or analytics platform, and they just need the data. They need to consume it, and then they combine it with the data they have, and that informs this tremendously rich and beneficial outreach process to the members. So we've been doing this a long time. Not our first rodeo. We do know data specifically, and that's why we believe highly that this process done correctly is very, very important. A lot of the questions we get are how easy it is to get the data out. Can it be, this way or that way? We've developed an engine that allows the use of this data very simply into existing platforms that you're using today, like your care management platform, maybe other platforms, disease management platform. You're triaging the data into the existing systems, and then from there, you're sending it out and doing things with that data. Another look into what does it look like to provide the member access to tools from a digital perspective. Let's say in the assessment the member has taken, this is a view into our platform. It's one of our demo platform sites. The member has completed the assessment. And from that, it's identified that maybe diabetes management is it's something they need to learn about. So they can complete a secondary assessment right online without reaching out. So then when they do connect with you, they're more informed about the condition, what they should be doing, diet changes, exercise changes, etc. There's a library of information that can be available to them related to health and pharmacy information. There's videos and relevant current articles. And then we've also, in this case, identified that this member might have an issue with food security and transportation assistance. So from a social determinant standpoint, because of the way they've answered some of the questions, we've identified that they have issues. And so using your resources, you have a vendor that you use for transportation when these issues come up. Well, why not connect them right away to access points where they can book a ride, where they can request assistance for a doctor visit? Why not provide them a connection to the local food pantry that's closest to them that can help them with the issue of food insecurity? So this is just an example of how we can use the platform that's proprietary we've built to support and serve your efforts from a plan standpoint. It matters. It matters to your member. Each member, one member, right? You do what you do for the purpose of supporting that member, meeting them where they are and providing them with resources and tools that help them along their health journey as a member. So when we start talking about data gems, how to take the data and compress it and make it into a ruby or an emerald or maybe even a diamond from a value standpoint, I've got a couple, I don't know if they're best practices as much as just bullets here around data gems. Number one, they're found by effort. There are some high level outlying, easy to find data gems that are easy, but sometimes it takes a little work. Sometimes it's going to take the initial look mirrored with additional data run through your BI platform. It may take a prediction with your predictive modeling engine to say, this member looks okay today, but based on socioeconomic factors related to XYZ, we see in 12 months they might cost X, right? So you're using the great tools you have, BI analytics, you're pairing this rich data source into that. It sometimes takes a little work, but the key is correct data. Efforts can be maximized by using valuable, vital, correct, leading data sources that inform the efforts that are existing today. Maybe you don't have anything going on today. Maybe this is a starting point. This is a great starting point to implement a health risk assessment, capture this data right away so that you can begin doing something related to outreach to the members. And then having a roadmap to support the members, right? Taking this data and then creating a roadmap. If a member is pre-diabetic identified at this initial contact, what should we do? You are working on these, you probably have these today. Continue to refine them, continue to make them better for the sake of your members. So engage your members with digital tools. I mentioned the area, two areas that we've talked about so far. Digital tools related to an outreach, having a multi-channel outreach support, creating a multi-channel out. Don't just rely on one medium. Don't just throw it up on your website and say it's good, right? There has to be a process by which you allow the member to communicate and receive information from you the way that they're the most comfortable. And then the second piece of it is, like I shared in our platform, we have a series of what we call action plans or self-management tools, as most of you would understand, that are NCQA certified. And in addition to our health assessment process, which is NCQA certified, that's the WHP 5 and the WHP 7. So you have this certified, you've got the stamp of approval there from NCQA that says the process is done correctly and it meets the criteria set forth by NCQA for both the initial data collection process, the initial assessment, and these supporting self-management tools. These tools are here to help the member once issues are identified, the member can self-educate, they can self-enroll in one of these programs and gain information and learn about a condition that they either have, just were diagnosed with, think they have, etc. They can learn about these conditions at their own pace without taxing the resources of your plan, which in my experience, every plan, everyone is wearing multiple hats. When you get into that care management outreach team or the member care teams, they're taking lots of phone calls, and the calls that they want to hit are the members that are the high risk. They're having the biggest issues, right? Because those are the ones that could snowball into larger issues. And so sometimes these lower tertiary level members are not receiving the information, the support they need as timely as they might want it. No fault of yours. It is a bandwidth issue. And so tools like this can assist with that process. All right, so we're wrapping up. Let me summarize what we've talked about today. Social determinants is the roadmap. It's the thing by which we are all, in a sense, governed to attain certain levels of quality for both our members and our plan related to the quality standards, NCQA, STARS, HEDIS, whatever the tools are, right, that we're using to identify our scoring as a plan. In addition to that, the goal is the outreach to the member. It's the connection with the member. It's helping the member. It's supporting the member. So social determinants help us from a roadmap standpoint to guide resources to the most needy members within our populations of manage. Actions should be configured by line of business. What we do as a plan, how we reach a member and communicate with them should be configured by line of business. The one size fits all does not work. That approach will not gain success across multiple member types. It may help you hit a goal if you said we've got to do XYZ, but it might not be the tools that the member needs to reach you, to reach your resources the most effectively. Data mining takes work. It takes work to consume multiple disparate types of data and identify members into specific plans or support programs where they can receive assistance and help with their conditions, etc. Leading data improves or empowers your efforts. There's no argument here. You guys are all saying, yes, I understand that. We need more valuable leading data in the front. We believe, as I said, and it's at the bottom of the slide again, I believe that the health assessment is the most important component in the initial member outreach. You have to place the call anyways. Why not during that time, or you have to mail the survey, or you have to send the letter, or you have to get them online to do something? Why not get all of the information you need in that initial assessment instead of creating these additional assessments that every time we do an assessment? Think about it. A company sends you a survey to complete about your experience with that company. The first time you might be like, this is great. I like it. I want to give my information. But then a few weeks later, you get another one, and then another one, and then another one. So why not combine as much as you can, combine the process by which you gather information from the member and share information about you, that initial enrollment period or the annual enrollment period. Why not combine as much as you can and take advantage of that time? Technology is there to support this process. You don't have to do this on your own. Your phone team doesn't have to manage the entire process on their own. Paper forms shouldn't be the entirety of the process, right? Technology is there to bolster. You'll find that the majority of populations, even Medicaid, even Medicare, they have some access to technology, and you can connect with them at some level using that technology. And then success is defined, right? How we define success, we say, well, if we've succeeded, we've done X. And so at the end of the day, probably you would say intrinsically, we have done our job and achieved success when we've helped X number of members to avoid a large claim issue, to curb this issue they had, to come off being pre-diabetic. They worked backwards. They got to healthy eating and figured out what was needed to move from that, to move the needle in the other direction so they don't continue to progress down the negative spectrum on their health journey. So again, the health assessment, we believe, most important component in the initial outreach process. That's all we have today.